We're grateful to have two hematology oncology experts joining us tonight. Dr. Ihab Batala from Medical College of Wisconsin will be presenting on CML, followed by a Q&A facilitated by Dr. Justin Klein at the University of Chicago Medicine. Dr. Klein is also the chair of our Medical Advisory Board. Dr. Atala, I will turn it over to you.
Thank you, Carrie. I will just share my screen here for a moment. So thanks, Carrie, for this introduction. I will, my goal today is to, in the talk, to just give an overview of CML, its treatment, some of the new therapies that are coming up, and then the rest, maybe for another half an hour, we'll be answering questions. These are my conflicts of interest. So we'll talk about the history of CML, just because I don't think everyone really knows how far CML has come overall and what was the treatment before. Discuss a little bit of choice of first-line therapy, discuss second-line therapy, and a topic that's really important to me, which is treatment-free remission. So this is the history of CML. And you can see that it was started out in 1845. I was not around then. And then the Philadelphia chromosome was discovered in 1973. And then from there on, from maybe 1975 all the way to 2001, if someone had CML, the only treatment was essentially a transplant. So there was also interferon that got maybe 10 to 20% of patients into remission. So it's either interferon, knowing that that doesn't really work that well, or patients go straight to transplant. Since 2001, imatinib was first discovered. Imatinib followed by dasatinib, nilotinib, followed by bosutinib, followed by ponatinib, and most recently last year, asciminib. So I'll start with the patient, newly diagnosed patient, 40-year-old lady found to have an elevated white cell count. And that's a pretty common presentation where patients frequently now go in for a blood count and the white cell count is high. Symptoms that could be associated with CML includes pain in the left side of the abdomen, fatigue, night sweats, hip pain. So this patient undergoes a bone marrow biopsy, confirms that she does have CML based on the Philadelphia chromosome. And we do have risk scoring system, and she has a low risk score. These are the questions I think that goes through everyone's mind if you are diagnosed with any disease or any medical issue. What caused this? How common? What's the treatment? How long will I live? What's the monitoring? And do I really need to stay on this treatment forever? So as you all know, the CML is caused by the Philadelphia chromosome. Essentially, chromosomes are the computer system of the cell. Chromosome 9 hooks up to 22, leads to messed up signaling to the cell, tells the cell divide, 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 divide. The second thing that CML is characterized by, other than the Philadelphia chromosome, it's characterized by three phases: chronic, accelerated, and blast. And without treatment, all patients will go through these three phases, and just about everyone would die in 7 years. Again, that's without treatment. That's just the natural history of the disease. With treatment, things are much, much better. So what are the options for first-line treatment? We have 4 FDA-approved drugs: imatinib, nilotinib, dasatinib, and bosutinib. Imatinib is described as first generation. Nilotinib, dasatinib, and bosutinib are described as second generation. And this was the first study using imatinib. And imatinib really prolonged survival and improved the survival of patients with CML. After imatinib was developed, then these 3 other drugs, nilotinib, dasatinib, and bosutinib, were developed and tested and approved as second-line therapy. And then came the question, could we give them upfront? Would we have better results if patients get these drugs upfront as opposed to waiting until imatinib is not working? So 3 different randomized trials, where imatinib was compared to nilotinib, imatinib was compared to dasatinib, and imatinib was compared to bosutinib. And with these trials, that's how these 3 other drugs got FDA approval for frontline treatment. So really, the choice of the frontline treatment with all the three drugs, survival is the same. There's no difference in survival with whatever drug the patient starts on, whatever drug you started on. They do lead to a faster and deeper response. There's a very small difference in the progression to accelerated phase and blast crisis. And we really choose based on side effects, comorbidities, so-called score, and honestly, sometimes insurance. Whichever drug is covered by the insurance, that also factors in into the decision, or the one where the patient has the least copay. So these are all the factors that when I discuss with my patient of the choice of frontline, these are the different things we talk about. After someone starts treatment, how do we define response? Like, how do we know if a patient is responding well or not? And response depends on two things: the depth of response and how long has the patient been on treatment. And looking at the depth of response, we mainly follow patients now with PCR of the peripheral blood. And you will hear all this MMR, log fold reduction, I think, or MR3, MR4, MR4.5. I think what I found it easiest to follow is really just follow the number. Forget about log fold reduction. I think it's just confusing. Just follow 0.1%, 0.01%, 0.00332%, or 0.001%. So that's a level of PCR. PCR is a test that looks at lots of cells and is able to identify 1 in a million cell that has the Philadelphia chromosome. And these are recommendations based on the NCCN guidelines. In general, in CML, we follow two main guidelines: NCCN guidelines, which is more US-based, and the ELN, which is the European Leukemia Network guidelines. And both of those guidelines are based on different studies of what we should do, how we should manage patients, what's the definition of a good response, etc. So you can see from this slide that it's recommended that a patient have a bone marrow biopsy up front, although a lot of people, that's a debatable point. So if you didn't have a bone marrow biopsy up front, that's okay, because it is a debatable point. And then thereafter, get the PCR checked every 3 months. And the responses are pretty straightforward. This has actually been recently a little bit more, this 2022. The responses are pretty straightforward. So for example, if someone's been on treatment for 6 months and the PCR level is more than 10%, that's not good, that's red, okay? If someone's been on treatment for 6 months and the PCR level is between 1 to 10%, that's green, that's good. So you see, ultimately, we would like everyone to get to below 1%. Once someone gets to below 1%, that's a really good indicator for overall survival, and that the disease will most likely not progress to accelerated phase or blast crisis. So what if someone starts first-line TKI and is not responding to it, is not following these milestones? The disease is not following these milestones. And the disease doesn't respond for one of two main reasons. First is adherence, which is simply taking the drug. And some patients have a very difficult time adhering to the drug, taking a pill every day. And that's an issue that really has to be addressed, because sometimes it's side effects that's preventing someone from taking the pills every day. The second reason is that actually the disease is resistant to treatment. And one of the reasons for disease resistance are these mutations that I'm showing here on the slide. And mutations, if you imagine that the BCR-ABL is a protein, and these drugs bind to the protein. Proteins are made of amino acids. So the drug binds to specific amino acids and therefore blocks the protein and therefore kills the cell. Sometimes these amino acids are replaced. And when these amino acids are replaced, then the drug can't bind and the resistance develops. And this happens in about half the patients who develop resistance. And it's really neat that what we see in the lab is translated into clinical work, because there are, according to the type of mutation, you can pick the drug that would work for this patient. So if a drug is not working and the disease is progressing, first thing I confirm that the patient is really taking the medication. And then I order a mutation analysis, and that guides me into what's the next drug that I should use. And following this, I have this whole table memorized. No, I'm kidding. I don't have it memorized. And you can look at this table and really decide which drug you're going to use. So for example, if you look at the T315I mutation, it's red all through. So patients who develop this very specific mutation, these 4 drugs don't work for it. And only 2 drugs, which I will talk about later, work for this very specific mutation, for example. So if someone takes imatinib doesn't work, gets switched to another drug, and this is resistant where patients are not responding, approximately half the patients will respond, and approximately the responders, about 3/4 will maintain the response at 2 years. Pretty good from going from imatinib to a second generation TKI such as dasatinib, nilotinib, or bosutinib. So now we talk about the 3rd generation, which is ponatinib. Ponatinib is a drug that works really well. And overall, about half the patients achieve a response. These are different levels of response. Cytogenetic response depends on the bone marrow, is not PCR. And specifically, what is really amazing about ponatinib is it works in patients who have this T315I mutation. So that's the first drug that the T315 that is able to treat the disease that has this mutation. Problem with ponatinib, though, is it has serious side effects, and the serious side effects are cardiovascular side effects. So it can affect the blood vessels of the body. And the rates that are reported are 27%. That's a pretty high rate. It was a pretty high rate because earlier on, we were not aware of this really significant side effect with ponatinib. Second is that when these were described, these even included if someone had chest pain that ended up to be anything else other than cardiac or other than the heart, it was still reported as a side effect or a problem, cardiovascular problem. More recently, there was a trial which helped to optimize the dose of ponatinib, starting at a higher dose and then reducing the dose when the disease is responding well. And with that strategy of starting at a higher dose and then lowering the dose, that actually has lowered these instances of cardiovascular side effects. I'm sorry for the slide said not FDA approved. That this drug is FDA approved very recently, a couple of months ago. No, sorry, 8-10 months ago. And asciminib just binds to a completely different spot. And the FDA approval was based on a randomization, a large trial, where patients who had 2 prior treatments, where then you flip a coin and they either received asciminib or bosutinib. And with this, asciminib was found to have deeper responses more than bosutinib in this group of patients who had 2 prior treatments. These results were also, this is at 24 weeks, and these results were also updated at 2 years, which is 96 weeks, and these results held up. Overall, it's well tolerated. Its main side effects are headache, some GI upset, nasopharyngitis, which is almost like a cold, which is a very unique side effect to this class of drugs, which is also reported with nilotinib. But overall, well tolerated. 10% of patients still get high blood pressure, which is something we need to watch for with asciminib. Bosutinib is known to cause diarrhea, and this was also seen here in this study. So asciminib also can cause low blood counts, which bosutinib can also cause, but asciminib can cause low blood counts and can also cause inflammation of the pancreas, which are things we watch for. So summary, CML is caused by the Philadelphia chromosome. There are 3 different phases: chronic, accelerated phase, and blast phase. Your choice for frontline TKI really depends. We have a lot of choices, really depends on side effects, other medical problems that the patient has, and adherence to TKI is very important for an optimal response, and mutation analysis is important when someone is not responding to treatment. So then we get to treatment-free remission. What are the chances that someone can actually go off drug? So when these drugs were first developed in 2001, that was in my training actually, we told patients you have to take this drug. This drug, you have to stay on it forever. Absolutely no chances of stopping. Later on, starting 2010, 2011, we started to have studies where patients who have been in a deep remission for a long time were stopping drug. So I'll discuss why should we stop the drug, who can safely stop, how, when someone stops, how should they be monitored, what's the outcome after stopping, and are there any side effects or benefits from stopping, and when should we restart? So why consider stopping? We know that with therapy, with TKI therapy, it is associated with reduced quality of life in about 30 to 40% of patients. So a little bit of fatigue, a little bit of diarrhea for the rest of my life is really not a good thing. It's not something that anyone would want to live with. If we have to, we have to. But if we don't have to, it would be great. There's really high cost to patient and society. And you all know this, that these drugs are really expensive. There are co-pays associated with it. There are issues of like moving jobs, changing jobs. Can I change my job, maintain my insurance, still get my drug? So these are all concerns I've heard from my patients. And as I mentioned earlier, starting in 2010, there were these studies that were coming out and saying, well, maybe there are some patients that can go off drug. Maybe that's a possibility. Lastly, which I won't go into details, are children and adolescents. It's a completely different story there. CML is very rare in children and adolescents, but in that group of patients, staying on drug forever is really not the best choice, and it does really affect growth also. So who can be considered for stopping? Who is the patient that we can discuss this with? So first of all, it has to be chronic phase CML. They have to have been on treatment for at least 3 years, a low-level PCR, which is below 0.01% for at least 2 years, an involved patient who's willing to come in to get the labs, and a multi-team approach for all this monitoring. So TFR eligibility, these criteria that I just described, does not happen to a lot of patients. So the ENEST-ND trial was the trial that compared imatinib to nilotinib, and that's how nilotinib got FDA approved frontline. That trial was recently updated with 10-year results, and about 50% of patients 10 years out fit these criteria that I just mentioned, which have been on drug for at least 3 years, have a deep remission for at least 2 years. So only half the patients actually become eligible for TFR even 10 years out. Once someone is eligible, they need to be monitored closely. So monthly for the first 6 months, every 2 months for 18 months, and then every 3 months forever. The reason it's done every 6 months in the beginning is if you look at this curve, this is where most recurrences happen. So that's why we watch them. Patients are watched closely for the first 6 months. The reason we keep every 3 months forever is that there have been some reported late relapses, even 4 or 5 years out. So if someone is successful in TFR and treatment-free remission, still needs to be monitored, get labs at least every 3 months to make sure everything is fine. So I just told you that we would stop patients if their level is below 0.01%. Some studies used a cutoff of 0.0032, either or. But below 0.01% has been shown to be safe in multiple studies for at least 2 years. However, the restart is with loss of 0.1%. I was just asked that question yesterday, where someone stopped, they had undetectable disease, and then it became detectable. Should I start right away? No, those patients shouldn't start right away. We know that it's safe. We know that in some patients, we have no clear explanation why some patients can have a detectable BCR-ABL, but really never develop clinical disease. So the stopping is at a level of less than 0.01, and the restarting is at a level of 0.1%. So someone could have detectable disease for a really detectable BCR-ABL for a really long time. 10 years out, these patients have not developed disease recurrence. So what happens when someone stops? So about 50% across multiple studies, multiple different TKIs, different parts of the world, about half the patients, if you look across all these studies, you can approximate that about 50% of patients achieve a successful TFR, treatment-free remission. But is it realistic? Is it something that we think will happen to every patient? I think we have to be a little cautious with how optimistic we are about that. So every 10 patients, if you think these are 10 patients with CML, I mentioned to you earlier that about 50% of them will get to that deep remission that we can even attempt a treatment-free remission. And of those patients that attempt to stop, half of them will need to restart. So realistically, 70 to 80% of patients with newly diagnosed CML will need to stay on drug forever. And these results we would really like to improve on and really get people to treatment-free remission and a cure, where patients would be off drug with no evidence of disease. That's what I would define as a cure. Are there side effects to try to attempt? Yes, there are side effects. When patients stop their drug, for some reason, they develop this joint pain. We have no clear explanation for that. It's very commonly in the hands. It usually lasts 6 to 12 months and goes away. In our study, we had approximately 170 patients, and 3 patients had to restart because of this musculoskeletal pain. There's definitely increased anxiety because patients have to come in, and that's what patients tell me. They have to come in, get checked every month, check their BCR-ABL. Am I going to need to restart? So it's anxiety provoking as opposed to where patients would just come in every 3 months and get checked. Lastly is more frequent monitoring. And this was really highlighted during COVID, where some patients really did not want to come in every month to get checked. So more frequent monitoring during COVID was really highlighted, but in general, monthly monitoring for 6 months is not very user friendly. So these are really the things I discuss with my patients when we attempt stopping. And I emphasize, the fourth point I emphasize is that, yes, your PCR may be undetectable now. Once you stop, it may become detectable, but that does not mean we need to restart right away. And we would only restart when the level is more than 0.1%. Are there benefits? Yes, there are benefits. We looked at the patient's quality of life after stopping, and fatigue, depression, sleep disturbances, and diarrhea all improved. Pain was very difficult to figure out. A lot of people have musculoskeletal pain with their treatment, but like I just mentioned, they also developed pain when they stopped. So it was very hard for us to quantify it in a large study. Did the pain really get better or not? Second benefit is to the patients, to the world, is cost savings. These drugs are very expensive, and even when they become cheaper, even when they become generic, still the patients with CML are living for a really long time, which is awesome. And the cost for these drugs remains to be really high. Not just the cost to the health insurance, but the copays that everyone has to pay, changing jobs, or concern for insurance and all that. So in summary, TFR is safe and feasible. In a select group of patients, we really have to pick the right group of patients. Close monitoring is required for patients. Quality of life does improve, and multiple studies aiming at deeper remission and increasing the number of patients that are cured. And we currently have the H. John Corey Cure CML Consortium, which is 19 sites across the United States of CML experts. And I'm sure you've heard a lot of my colleagues that are part of the consortium talk in different venues. And our goal is to really get more patients to a cure. We have a frontline study using asciminib to see if we can get more people to a deeper remission. We have 2 other studies looking at treatment-free remission. We have second treatment-free remission, where someone who tried to stop had to restart the drug, and then we're giving them another drug to try to get for a year to try to get them off drug completely. And we also are starting hopefully we get NIH funding to start a large registry to collect long-term data on patients in the real-world setting outside clinical trials. So with that, I think I am at time, and would be happy to take any questions.
Thank you so much, Dr. Atala. Very helpful. And just a reminder to everyone on the call, you can enter a question into the Q&A box. Otherwise, we have several questions that were submitted in advance that Dr. Klein will be addressing now with Dr. Atala.
All right, and you have a wonderful overview of CML. I learn something new every day. So the first set of questions has to do, perhaps not surprisingly, with treatments. The first is, how long does one need to be on Sprycel and in complete molecular remission before going off Sprycel? Do you stop the medicine all at once or reduce dosage for a period of time before stopping completely?
Okay, so we'll take it piece by piece. So how long does someone need to be on drug? So most studies included patients that were on drug for at least 3 years. We know from most studies that the longer duration, the more likely the success of a treatment-free remission. So if someone is at 3 years, yes, they can stop, preferably 5 years. So on drug, 3 years, preferably 5 years. Deep remission. So it doesn't have to be complete. Again, if it's below 0.01% for at least 2 years, that is acceptable. So that was second question. Third question, can you reduce the dose? So yes. So it can be done one of two ways. Either just stop right away, or there was a UK study, and I think it was only the UK study. It was called the Destiny study, where they took patients who, for example, were on 100 milligrams of dasatinib, cut the dose in half for a year, and patients who remained at a low level, below 0.01%, then they stopped. So it can really be done either way, either reduce the dose for a year and then stop, or stop right away. I've found that there are some patients that really feel nervous about the stopping right away and feel much better about the reduced dose approach.
Great, thank you so much. Another question. Since my diagnosis in February of 2019, I've been on dasatinib, nilotinib, and for the past 18 months on bosutinib. I'm aware of asciminib and ponatinib. I'm very interested in what other treatments there are and what is on the horizon.
So yes, ponatinib and asciminib would be the other options. I discussed those briefly, pros and cons of each. There are other treatments on the horizon where ruxolitinib is being combined. Ruxolitinib is a JAK inhibitor, which is FDA approved for a different disease called myelofibrosis. And that in combination with a TKI, we think might work better. There are other studies using our immune system, a drug called Pembralizumab, which is run through the cooperative groups. And Pembralizumab essentially just boosts the immunity. And we think that's one of the ways that we can possibly cure CML, possibly. There are other tyrosine kinase inhibitors, which are similar in that same group, but but bind better. Or in a different way, but they are in the same group. So those also are being developed. There are other drugs. One is called an MDM2 inhibitor, essentially pushing the cells into committing suicide or into apoptosis. So these are the studies that are currently in the US and available. And doing research in CML is hard, as the results are good. They're not perfect, they're good. And patients and physicians are not willing to put a patient through a lot of side effects in order to try to get to treatment-free remission. So there's that balance of like, I need something that works better than these really good drugs, but I also don't want my patient to get lots of side effects. So it's a balance that we're working through. In all our studies, we've had patient representation for all our studies to make sure that we're doing the right thing for our patients.
Yeah. Yeah. It's almost, you know, an effect of having treatments that are quite good. You know, it
Yes.
becomes tougher and tougher to test new drugs in that landscape. That's for sure. There's a question about discontinuing spry cell and developing sort of resistance to it in the context of discontinuation. And this is somebody who's been on prior Gleevec, Tasigna, and bosutinib treatments. So I guess, what is the likelihood that, say, somebody stops a BCR-ABL inhibitor and then develops resistance if they need to go back on?
So we know that if the level of response is really good, like we talked, like the eligibility for TFR, practically everyone goes back into remission. With two caveats in that story. Is for someone who's been on multiple TKIs, everything I've talked about mostly has been frontline, people who are not resistant. We do have some data for someone who was resistant to imatinib and then switched and then stopped. It was also safe in that context. But once you get to fourth line, we really don't have data for safety stopping in fourth line. And there's a difference between stopping when someone is in deep remission or stopping when someone is not in a deep remission. We know if we stop with someone who's not in a deep remission, there is a chance of developing resistance and the disease progressing. So it depends on where the disease is at the time of stopping.
Got it. Okay. Questions about life expectancy of persons diagnosed with CML in today's world.
So the Swedish registry data showed that the survival was similar to the general population. Our US SEER data didn't show that. Survival of patients with CML in the US is lower than the general population. We don't know why that is the case, and that's one of the reasons we're setting up this large registry to try to understand that more. Is it because we don't think it's because of CML? Maybe it is, we'll learn that. But is there a chance it's because of the other medical problems that we as a population have, and that these drugs exacerbate more, and that's why survival for patients with CML are lower than the general population? Still really good, but lower than the general population.
Got it. And how often in say somebody taking imatinib are you who's at an MR4 or deeper, are you seeing them? Are you checking their blood work? I noticed, I think you mentioned every 6 months for PCR testing. Do you see them more frequently that, or are you seeing folks twice a year typically when they're doing really well?
So typically when they're doing really well, I still the guidelines say once someone is in a deep remission, you could do 3 to 6 months. I still stick to labs every 3 months. I think close follow-up is important. So in my practice, I do labs every 3 months, and clinically I see patients every 6 months or a year, depending on how comfortable they are with sort of almost remote monitoring, where they look at their labs and they feel things are fine. The other thing too, it also makes a difference with how far the patient lives, because now we could do virtual visits. So I do the virtual visits every 6 months to a year and monitor the PCR every 3 months.
Got it. And are you regularly doing bone marrow biopsies in folks diagnosed with CLL, either at the point of diagnosis or for disease monitoring, particularly those in the first line of treatment? So
at the time of diagnosis, I still do a bone marrow biopsy. If someone tells me I really, really don't want bone marrow biopsy, an older patient, I'm okay with not doing that. As CML experts, we have agreed to disagree on that. Some CML experts insist on it. Some CML experts think, no, you don't really need it. I sort of fall in the middle. Like, I would prefer it, but if the patient really, really doesn't want it, it's okay. After the diagnostic marrow, I only repeat the marrow if there's no good response. If something looks different or unusual, but otherwise peripheral blood PCR monitoring is what we do.
That makes sense. Question about what is the soonest you've seen a patient achieve TFR?
I never stop anyone before 3 years of treatment.
So 3 years, we're gonna hard and fast on that one.
Correct. Never stop anyone less than 3 years. Because again, the longer you walk, like I talked to my patient about it at 3 years, but really 5 is better.
Got it. Got it. I'm sure that's those are some interesting discussions. There's a question about CAR T. It's pervasive. I read about a young leukemia patient who was cured with CAR T cell therapy and 10 years later is cancer-free. She had been diagnosed with ALL, or acute lymphoblastic leukemia. Could this treatment work for CML patients now or in the future?
So CAR T is an amazing therapy, still has significant side effects. It's worked really well so we have white cells, and then with the white cells, there's 5 types of white cells. With the 5 types of white cells, there's 2 main types, lymphocytes and neutrophils. Cancers that have arisen from the lymphocyte group, CAR T cells have worked really well for them. In the cancers or leukemias that have arisen from the neutrophil part, it hasn't really panned out till now. So short answer is I don't think CAR T cells will have a role in CML, especially with how well these drugs work. And I was mentioning earlier that the toxicity to put someone through a CAR T cell, for example, with CML, where you could take a pill, do relatively well. Of course, there are side effects, as opposed to going through a CAR T cell. I think the risk-benefit ratio is too high. Do you agree, Dr. Klein? Would you?
Yeah, I agree. I mean, just as you said, sort of the blood cancers that are derived from B cells can be targeted easily with CAR T cells. The problem with CAR T cells is they can't tell a healthy B cell from a cancer B cell, and so one of the downsides of CAR T treatment for the types of cancers that I typically treat is that people are left without B cells and without antibodies for long periods of time. Turns out that most people can live pretty well without B cells, but trying to target stem cells, blood stem cells that cause CML, leads to a lot more complications. Can't live without your neutrophils and your macrophages and so on. So unless we can identify a specific target on CML cells, which seems a little bit unlikely, I would agree with you entirely. Who knows? Who knows what the future holds, though?
Who knows?
Somebody will maybe identify some snappy target on CML cells, and we'll be talking about CAR T cell therapy 3 years from now or something. But for now, I would agree with you. There's a question about where a person can find what clinical trials are going on for CML.
So 2 things. We do have the H. John Corey Cure CML website, which is curecml.org. It's not a great website. We will update it. That's one way. The other is looking to clinicaltrials.gov, and that's the government website. And if you type CML in there, you'll be able to see the clinical trials that are ongoing in CML.
Great, thank you. And there's a question about Tasigna and its relation to causing lymphomas. Lung lymphomas is the question, but I think lymphomas in general, is there any relationship? And then does CML lead to other cancers? Two separate questions there.
So question 1, has there been a high incidence of lymphoma with Tasigna? I am not aware of any reports that have reported that have shown that. I don't know that. Okay, so I don't know if the question is stemming from that someone or you have CML and developed lymphoma. What we're seeing, because patients with CML live for a really long time, we are seeing other cancers. We don't think that they're related to CML or the treatment. It's because patients are living longer, so they develop other cancers. These questions will be answered better with the hopefully not with the registry we're developing, but as of today, we're not aware of any increased risk.
Got it. So these are presumably second primary cancers that are presumably unrelated to the person's CLL. Okay. I actually have a question about the Pembralizumab that you talked about. in the old days when we were using, well, I guess you and I are probably similar in age, but when transplant was being used regularly for CML, it was clear that when folks had recurrences from transplant, you could give donor T cells or donor lymphocytes, and that could, in some cases, induce really long remissions in folks with CML. So it suggests that this is a disease that's really primed to respond to immunotherapies. And I was curious, is there any preliminary reports or evidence to suggest that these immunotherapies like Opdivo or Keytruda, as I'm sure people have seen the commercials, that they're effective in CML at all?
So preclinically in the lab, they seem to be effective. I can tell you the study has been open for quite a while, and accrual to the study has been really low. Yes, because, and I'm glad we have patients on the phone with us, it's an infusion that's every 3 weeks, carries the risk of activating your immune system, causing side effects. So I am guessing that when patients hear that, you're like, well, I'm doing okay. I'm doing fine. So the Pembro study is taking patients who are doing okay, and you're trying to push them into that deep remission so they can stop the drug. So I'm guessing that's where the hesitation is coming from. But the study's still open. We're hoping to accrue some patients and learn from that.
Yeah, that's great. Thank you. That was my own curiosity. There's a question about what you recommend for chemo brain. This particular person has been taking imatinib or Gleevec for 16 years. Wow.
So if you are responding well, there's no fix for the chemo brain. The fix for the chemo brain that I have seen, or the confusion or the fogginess that patients describe, is if you are responding well, you could do one of two things: reduce the dose down to half, or stop. But these are definitely conversations you need to have with your physician to, based on your response, your history. Was imatinib the first thing you were on? Can you come in for a lab? So there's just lots of things that need to be addressed with your physician. But I would discuss that with the physician. Can I reduce my dose? Am I in a place where I can stop?
Yeah, chemo brain is something that as oncologists that we hear about quite a bit, and I think often feel a little bit powerless to make much headway on, because we really don't, at its core, understand exactly what causes it. And maybe there are different causes in different people, but I always struggle with how to counsel folks who are dealing with chemo brain, but I do hear about it frequently. And for time limited therapies that we're offering for most, blood cancers, it tends to get better with time. But of course, if you're on imatinib for 16 years, it is what it is. Okay, let's see here. What are options for dealing with the chronic pain of CML, which I wasn't aware was a common thing, but perhaps I'm naive.
So the chronic pain is usually not really from the CML, because the CML is responding well. The CML shouldn't be causing any more pain. The drugs can cause musculoskeletal pain and fatigue being more common than musculoskeletal pain. Fatigue, if you look across all drugs, fatigue happens at about 20 to 30%. And the levels of fatigue vary with age, with activity. Younger patients feel fatigued as they can't play basketball, right? I mean, so that's significant fatigue to them, right? The musculoskeletal pain is one of the common side effects. There's really no clear fix for it, other than what I mentioned earlier. If the response is good or great, discussions with the physician could be, can I reduce the dose? Am I in a place where I can consider stopping? These are really the two options for the musculoskeletal pain.
Got it. And there's a question about the cost of treatment, and I know you showed a slide about this toward the end of your presentation. But it really is, it's high. It's excessive. So are there ways, opportunities, options for folks who may, have high copays for some of these BCR-ABL inhibitors that you're prescribing in your clinic? Perhaps Carrie can follow up. I'm sure she's got some thoughts on this as well, but I'll let you go first.
So imatinib is currently generic, and there are many generics on the market now. I think close to 8 or 10 generics for imatinib. The Mark Cuban pharmacy, which I don't work for Mark Cuban, I'm not advertising for his pharmacy. However, imatinib in the Mark Cuban pharmacy is about $50 to just buy it out straight out.
Wow.
Yeah. It's still money, monthly payment that people are not expecting or don't want to expect, but that's how much cheaper how cheaper it's gotten now. The dasatinib and the nilotinib will soon be generic also. By soon, I think within 1 to 2 years. It takes maybe another 4 to 5 years for generics to actually become cheap when you have multiple companies making them. But we're getting there. The cost is becoming hopefully addressable. I have to say a lot of the companies have had really good support in terms of helping patients. I think, of course, they have a benefit in doing that also. Working with someone, working with a social worker to try to get all possible support from even patient support groups like this one we're at is always very, very helpful.
Great. Thank you so much. And Carrie, I'm going to turn it back over to you in case you have any comments on that last question, and then to sort of wrap us up here.
I think Dr. Atala did a great job and said a lot of the things I would have said. I would say that on our website, if you go under patient and family support, other helpful resources, there's a whole financial assistance section that offers some suggestions and links for pharmaceutical assistance, as well as searchable databases for financial support as well. So I can type that into the chat if people want to see where that link is. Right. Were there other questions, or are we wrapping up?
I think we got to all those
to
you could see.
most of them, yeah.
Yeah. We had you on
Excellent.
the hot seat
Okay.
there for a minute.
Yep. So I just wanted to say that if you found this Q&A portion of the program very helpful to you, we have a leukemia Q&A program coming up in February. We're going to do one for chronic leukemias and one for acute leukemias, where we'll have a panel of experts, and it will all be focused on patient and caregiver questions and answers. So thank you to Dr. Atala for putting the time into developing this presentation and for being with us this late in the evening after a long day, I'm sure. And same to you, Dr. Klein, as always, for your support of the foundation and for making this a very meaningful Q&A. So with that, I would also ask you, please fill out the evaluation. I will send it this evening. It really helps us improve our programs as we move forward. And the recording and the slides will be sent within the coming days. So thank you again and have a great evening.
Thank you so much, everyone. Bye. Good
Take
night.
care, guys.